Okay, so it is my great pleasure to introduce the speaker that I know best today, Brenda Colella, because we are in the same lab. Brenda is from the Toronto Rehab Institute at UHN, and she's going to talk about preliminary efficacy and predictors of response to a symptom self-management program for individuals with persistent symptoms after concussion. Brenda is a registered psychological associate practicing in the area of clinical neuropsychology. She completed her undergrad and grad studies at the University of Toronto. Since 2017, she's been involved in the development and establishment of the Tele-Rehab Center for Acquired Brain Injury at Toronto Rehab, UHM, where research is fully integrated with clinical care. The research focus at the center is the development of mechanism-based treatments to prevent declines in chronic brain injury, as well as evaluating the feasibility and efficacy of remotely delivered interventions to improve long-term cognitive and emotional outcomes after brain injury.
Just me officially the only person who needs notes. That's okay. So just a second.
Wouldn't have known that if you didn't tell us.
Just a second. I might just need, oh, there we go. Yeah. Pardon? Oh, there we go. Hi, Steve. Oh, I think it's good. Yes. So good afternoon, everyone. Thank you for staying for these last talks. Today, I'll talk about an education and strategies intervention that we developed to improve the capacity to self-manage the persisting symptoms of concussion and to improve mood and quality of life. I'll present data on feasibility, preliminary efficacy, as well as predictors of response to treatment. So just to provide some context, this study took place in a clinical setting, the Tele-Rehab Center for Acquired Brain Injury at C.E.T.S. And here we receive referrals from all over Ontario, from hospitals and community-based organizations and clinics. These referrals are for individuals in the chronic stages of acquired brain injury. And these include mild to severe TBI, stroke, and other neurological disorders. We deliver a range of treatments and interventions to these patients remotely and in group format. One of our main aims at the center is to integrate clinical care and research, which allows us to improve interventions and also to develop new treatments. Concussion referrals make up 48% of all of our referrals. And so we decided that we needed to develop the Concussion Education and Strategies Management, or C.E.S program to address this need in this population. There is some evidence that early education can minimize the development of prolonged symptoms, and this approach has been successful for management of non-specific symptoms in other populations, such as chronic pain and cancer. And this intervention is based in part on this research, but also draws on content from the Ontario Neurotrauma Foundation guidelines for concussion management. So the main aim of the study is to evaluate this concussion education and symptom management program. Our key objective our key objectives were to examine feasibility and efficacy of the program, as well as starting to look at predictors of response to treatment. And this third objective is necessary for helping us to determine how generalizable the intervention is. And also it helps us to predict who can benefit from the treatment and should thereby receive the treatment versus those who may not benefit from the treatment, which would help us to determine how to modify the treatment to going forward to enhance benefits for these individuals. As you know, anywhere from 10 to 40%, maybe more after Dr. Tortalia's talk, of people experience prolonged cognitive, physical, and/or mood-related symptoms after concussion. Symptoms can last months to years, and they're important because they're associated with very significant disability and reduced quality of life. Some individuals are at greater risk or high risk for a vicious cycle to develop that may serve to prolong symptoms. For example, the injury we know it has the potential to cause somatic symptoms, cognitive symptoms, as well as emotional sequelae in the immediate post-injury period. If these do not spontaneously recover, or they're not addressed early on, it is possible that some symptoms can exacerbate other symptoms that may be present. For example, sleep disruption, low mood, these could exacerbate cognitive issues, attentional problems, for example. And these secondary symptoms interact and they influence each other so that people get stuck perpetually in this cycle of symptoms, physical, cognitive, and emotional. The good news is that if the cycle could be broken, if one symptom could improve, then we could expect to see improvements in other symptoms as well. So the program provides education about persisting symptoms, including information about the interplay between symptoms. The program also offers concrete recommendations to help address these symptoms, and both self-care strategies and evidence-based treatments for specific symptoms are discussed. There are 6 sessions, 2 hours each, led by a psychologist with 8 to 12 participants in the group with their videos on. Here's the general content of each session. The first week provides general background information about concussion and acute effects. The second week starts to delve in managing prolonged symptoms more generally. And then weeks 3 through 6 focus on the prolonged symptoms, specifically physical, cognitive, and mental health symptoms. And I'll let you just take a moment to look through that. And maybe I'll just mention that the ONF guidelines recommend a symptom-based approach to treatment without diagnostic assumption for individuals experiencing prolonged symptoms of concussion. And this program takes that approach. So I'll be reporting on results from 80 individuals who completed the program and consented to use their data for research purposes. This table shows some of the sample characteristics, and it's a sample of community-based individuals with chronic persisting symptoms from a single concussion and some multiple concussions. The main exclusion criteria were that the person had to be, if the person was less than 6 months post-injury, psychosis was an exclusion, as well as an inability to communicate in English. To measure the feasibility of this approach, we examined retention and adherence, including session attendance and completion of pre and post outcome measures. We also used a participant feedback questionnaire to measure acceptability of the program. For preliminary efficacy, we employed a single group pre to post-treatment design, so there isn't a control group, but we can still learn a lot. Our primary outcome was the perceived medical condition self-management scale. This is a measure of perceived competence for self-management behaviors in patients with chronic medical conditions. And our secondary outcomes were the depression, anxiety, and stress scale, as well as the quality of life, enjoyment, and satisfaction questionnaire. We used linear mixed effects models to examine pre to post-treatment change on primary and secondary outcome measures. We also examined predictors of response to treatment. These included demographic factors such as age, years of education, and time since injury. And we looked at self-reported symptom burden following concussion. And what we know is that, self-reported symptom burden has been associated with poor outcomes, including more persistent symptoms, reduced exercise tolerance, and lower post-injury resilience. Also, as Dr. Tartaglia mentioned earlier, high symptom burden is negatively impacts return to work. So using the number of cognitive, physical, and emotional symptoms reported at intake as a proxy for symptom burden, we explored whether this was associated with response to treatment on our primary and secondary outcome measures. And this table is here to show the mean number of symptoms reported across each of those domains. We operationally categorized people into low and high symptom burden for each type of symptom. For cognitive and physical symptoms, greater than 4 reported symptoms was the cutoff for high symptom burden, and for emotional symptoms, more than 3 symptoms, you were in that high symptom burden category. For the feasibility results, I'm presenting the data for all clinical referrals admitted to the center who were offered concussion education and symptom management. 138 clinical referrals accepted a spot in a concussion education and symptom management group that ran between November 2019 and January 2022. You can see from this table that overall retention, adherence, and completion of online outcome measures was very high. With regard to findings from the participant feedback questionnaire, overall acceptability of the program for our participants was high. 79% participants, the program met their expectations. 93% were glad they participated. 83% agreed that the program met their needs. The content was also well received, with 93% finding the content relevant and appropriate, 96% finding the presented information clear and understandable, a little bit more variation with length of program, 6 weeks, 63 agreeing that the length was just right, 20% endorsing that it was too long, 17% endorsing that it was too short. I'll now take you through the efficacy and predictors of response to treatment findings. These results include only those 80, the sample of 80 participants I showed you earlier. These are the ones who completed the program and consented to having their data used for research. I'll start with a couple of general findings that apply to all of our outcomes, and then I'll take you through a more fine-grained summary of the results. So overall, we found pre to post efficacy for all of our primary outcome, as well as for the secondary outcomes, depression, anxiety, and stress scale, and the quality of life, enjoyment, and satisfaction scale. Interestingly, the demographic predictors did not have a significant impact on any outcomes. We think this is a good thing because it may mean greater generalizability of this intervention, since patients benefit regardless of their age, their level of education, or their time post-injury. Now for more specific findings, as I mentioned, there was a significant pre to post improvement on our primary outcome, the measure of self-confidence to self-manage symptoms. With regard to predictors of response to treatment, I'll direct your attention to the 2 line graphs on the right. They illustrate the results for cognitive and physical symptom burden as a predictor of treatment response. If you look at the graph at the top right hand of the slide, we found a significant interaction between time, so pre to post, and cognitive symptom burden. Specifically, looking at the blue line, individuals with low cognitive symptom burden at intake showed greater gains in confidence to self-manage after the program. The same interaction was observed for physical symptom burden. In contrast, individuals with higher cognitive and or physical symptom burden, the red lines on the graphs showed little to no change in confidence to self-manage. In other words, being highly symptomatic in the cognitive and physical domains really gets in the way of benefiting your confidence to self-manage. Again, for depression, anxiety, and stress, there were significant pre to post improvements. Here, if you were high on emotional symptoms, the program reduced your symptoms. We think this is because if you're highly symptomatic in the emotional domain, then there's a lot more room to improve on this measure. For the quality of life, enjoyment, and satisfaction measure, there was a significant pre to post improvement. And I would say that the predictors results here are a little more complicated. Essentially, patients with both low and high cognitive symptom burden improved on quality of life. But those with high emotional or physical symptom burden did not. And those who had high emotional or physical symptom burden also had a lower baseline quality of life. So maybe just as a summary, it's a lot of information. Overall, the preliminary evidence suggests that CESM benefited patients for all of our outcomes. So confidence to self-manage symptoms, mood, anxiety, stress, and quality of life. And these findings offer promise that adults of a wide range of demographic backgrounds and type of injury can benefit. But what impeded response to treatment? Well, if you have high cognitive symptom burden, your confidence to self-manage does not improve. If you have high emotional symptom burden at baseline, you have lower quality of life. Your quality of life does not improve with treatment. Your confidence to self-manage symptoms does not improve, but your emotional status, at least in the short term, does improve. If you have high physical symptom burden at baseline, you have lower quality of life, and your quality of life and your confidence to self-manage symptoms does not improve. This program helps your depression, anxiety, and stress if you have high symptom burden of any type. So what are the clinical implications? We know these data are preliminary, but we want to start to maybe translate the findings into some clinical recommendations around who we can recommend it for. For example, if the goal is for someone to manage their own care, we recommend it for those with low symptom burden. If the goal is to try to improve quality of life, we do not recommend it for people who have a lot of physical symptoms. And if the goal is to improve depression, anxiety, and stress, at least in the short term, we recommend it to patients who are emotionally distressed. We know that an education intervention can only do so much, right? This type of intervention is very different from a targeted intervention for individuals who have specific areas of difficulty. But how about those patients who are receiving these targeted interventions, targeted to their clinical needs? For example, we deliver goal management training to individuals who have higher level attention and executive difficulties with prolonged symptoms of concussion. And when we run the same analyses looking at efficacy and predictors of response to treatment on our primary outcome for goal management training, which is the cognitive failures questionnaire, we find, again, significant pre to post treatment improvement on the cognitive failures questionnaire. When we looked at predictors of response to treatment, again, patients benefited regardless of their age, time since injury, or education. However, different from the CESM program, when we looked at symptom burden, either physical, cognitive, or emotional symptom burden, high symptom burden did not impact negatively on pre to post benefits or on retention of benefits at 6 to 8 week follow-up. So that shows you kind of obviously the positive side of the CSM program that we've described, but also that there are limitations. So there's only so much we can expect to do with the education program. People need targeted interventions to address their symptoms. So what are our next steps to determine how to improve response for non-responders? And I've listed a few points here, as well as the examination of the intervention with a randomized controlled trial methodology. Thank you.
Thank you, Brenda. I'm kind of biased, but I thought that was a great presentation. Go ahead, Carmela.
Yeah, great presentation, Brenda. And we're very happy that this is available to our patients. And along with you, we really do think that we need precision medicine for these people, just like you have in other areas. And just thinking about that, is there, thoughts of maybe combining this? Maybe somebody with, many physical symptoms would need this with like physiotherapy or occupational therapy or psychotherapy, and looking at more of these combined multidisciplinary, if you have some of the other
symptoms. Such a great idea, Carmela. So we would love to do that. And I think those are modifications and studies that we could definitely embark on. certainly we would have to modify things for the people with a high physical symptom burden. There's no point for them to sit through this entire 6 weeks if they're not benefiting. But if we made it more targeted to their needs, I think we would see the benefit. So adding the physio component or treatments to address like the chronic pain aspect or other physical issues. For sure. Thanks.
Any other questions or comments? I know Brenda's trying to get the thank you slide with all the lab members that participated up, but it's okay.
It seems impossible at this point. So thank you, everyone, and especially our lab members and center staff and participants.
Oh,
So have you considered that those that may repeat of the program as the program is beneficial, but it takes longer to repeat?
That's a very good point. We haven't considered having them go through the program again. I guess that might be an option if they were to report to us that they feel they benefit from repeating it. I guess it's a resource issue too, because these patients, there's a limited number of these groups and a cutoff for how many in the group. But yeah, we could consider it. For other interventions at our center, we actually do allow them to repeat the mindfulness or the goal management training if they feel that they, for some reason, missed a chunk of it. So we should consider it too.
Yeah.
Yeah. Thank you.
Thanks, Brenda.